welcome you to be with us, and very pleased that you're with us today. And thank you, and apologize in advance that our guest and lecturer is not here on the call at this point. But I'm going to share with you a couple of soft tissue cases that may be of value for you. And so we'll begin with a lesion that occurs in the extremities. This is a lesion that is generally equally identified in male and female adults, and can have an interesting differential diagnosis. This, as you can see, has a somewhat cellular appearance, and then you'll notice these very pinkish purple areas here, which as we come into higher magnification shows us some of the very hyalinized collagenous and somewhat serpiginous or rounded areas that often tend to focus around a vessel. You'll see several of these here have a central vessel in this lesion. And so this is a proliferation that has some vasculature in between these hyalinized areas. You know, we can look at these cells and see that they're a degree of pleomorphism, some variability in the nuclei that shows some degree of atypia, and a little bit of, extravasated red cells associated with this lesion. So this is an example of a pleomorphic hyalinizing angiectatic tumor, or PHAT, as it's been called, and is not a very common lesion, but is certainly something that can be encountered in a variety of settings. But as I said, generally an adult tumor that involves the extremities. And it's actually more common in the lower limbs. This tends to be slow growing and may have this sort of inflammatory component. You can see a little bit of a sort of background inflammation in this lesion. It's been, because of the angiectasia, sometimes these lesions will have a fair amount of pigment deposition. And actually have one other example of this lesion here as well, which I can show you. And you can see here is the kind of angiectatic component to this lesion. And it has a lot of hemosiderin associated with it here. So here's a vessel, looks like it's almost been thrombosed and recanalized in this lesion. And that certainly would be, nice explanation for why you get so much hemosiderin, is that there's some degree of vascular instability. And that process may be what leads to the angiectasia in these lesions, or the hyalinization in the lesions. The more cellular area of this tumor, you can imagine getting a biopsy of this and kind of wondering, what would I do with this if this was my biopsy? I certainly wouldn't jump to the hyalinizing angiectatic feature based on a field like this. So you have to recognize that if you're dealing with a small biopsy sample, this may be have a variable degree of cellularity. And as you can see, it has a little bit of this infiltrative characteristic in the surrounding fat. So this is a lesion that can be somewhat challenging on small samples if you don't have the characteristic angiectasis and slight degree of hyalinization that may be associated with that part of the tumor. Now, there is some evidence that this tumor, at least behaviorally and molecularly, genetically, has some relationship with a couple of other soft tissue tumors, specifically the myxo-inflammatory fibrosarcoma and the hemosiderotic fibrolipomatous tumor. So that is a differential to be considered at times with this lesion. And those are, again, more uncommon lesions as well. So I think it's just nice to sort of see some of the spectrum of disease in this type of tumor and consider what you might do with biopsies that include variable amounts of this kind of process. Here you see some of the inflammatory infiltrate that we can see with this lesion. So I'm going to come back here to my panel of discussions. And I've got a nice sequence here of solitary fibrous tumors that we've mentioned could be seen in the differential considerations of this. And so let's take a look here. The solitary fibrous tumor obviously is a relatively common soft tissue tumor. I think over the course of my lifetime, it's been seen and described in virtually everything. But when I was a resident, I can still remember my very first case of this lesion, which was a thoracic lesion that was thought to be a huge cancer and was ambitiously resected and discovered to be a fibrous mesothelioma, or the precursor names for this tumor, that was somewhat pedunculated and attached to the mediastinal pedicle. And so the patient was cured. I think they had a paraneoplastic syndrome, may have even been a MGH CPC at that time. But it was a great learning experience for me. But now we see this tumor in so many different locations in the head and neck, intra-abdominally, soft tissue sites, and so forth. In fact, in our institution a few years back, one of our residents and I reviewed the occurrences of this lesion in the liver and pancreas, just to kind of complete the spectrum of things that you might encounter. So the characteristic phrases associated with this are the patternless pattern. It does have a morphology that shows you a variety of lesions, a variety of patterns, small spindle-shaped areas and so forth like this. But there can be areas of, vascular change. One of the patterns that has been described is the so-called hemangiopericytoma-like pattern, where you can get fairly ectatic vessels. Let's just take a look at another example of this tumor to get a little bit more feel for this variability. And this is actually a frozen section, but I think you can appreciate here these what are typically called hemangiopericytoma-like vascular patterns, where you get these ectatic, irregularly shaped, thin-walled vessels surrounded by these fairly cellular areas of stromal mesenchymal cells. And so that's one of the patterns that you can recognize. This, of course, derives from a time when we thought there was a distinctive tumor called a hemangiopericytoma, more common in the brain and CNS than elsewhere. Hold on here just a second. I'm going to try to take this phone call because I think this may be our Okay, I'm back and pleased to report that our guest lecturer will be available, and we will do his session with the cases that we put out for preview next Friday. So 1 week from today at this time, Dr. Adeyi will be with us for his discussion on biliary lesions. So another feature that is described in solitary fibrous tumor is the feature of ropey collagen. Here's another example, this obviously showing very nice ectatic vessels, variable cellular areas. But the other feature that I wanted to refer to here is this feature of ropey collagen. And I think what that's referring to is sort of a sometimes twisted or very coarse collagenous background that you see here. Some hyalinization, I mean, this could also be described as hyalinizing angiectasia, like the tumor that we saw earlier. But that is another feature that I think goes along with some of these vessels, and this has this sort of a sense of sort of twisting or fibrillar collagenous background. So those are some of the histologic, histomorphologic features that we associate with this tumor. I've got a couple of examples, I believe, that show us some of these again in the spectrum. Now, I think in studying any lesion like this, it's very useful to see a spectrum of the kinds of cases that you might encounter in your practice. And so in doing that, or in looking at various cases, this is not always a situation of you've seen one, you've seen them all. In fact, when you've seen one, you've oftentimes just seen one. And you need to remember that these diseases can have a relative spectrum of changes and features that can be distinctive. And of course, that's based on sample size and so forth, that you may get an area that's less distinctive or more distinctive. Here's again some of this sort of ropey, twisted collagen that we can see with this lesion. Now, I'm sure you recognize that the defining features for solitary fibrous tumor today are based largely on the fusion gene presence of a distinctive protein that is not normally expressed in most other soft tissue tumors, and certainly not in most other spindle-shaped tumors, and that is the STAT6 marker. We have various fusion partners with the STAT6 gene, but the end result is that marker is expressed to a much higher and greater degree than in virtually any other tumor. So that becomes a very useful and specific marker when you're dealing with a differential like the pleomorphic hyalinizing angiectatic tumor or other sort of lesion. Because of the different features that can be present in solitary fibrous tumor, the myxoid areas, the presence of possible verrucae bodies and other sorts of things, it is very useful to have a unifying stain like that. And in fact, let me just jump down to what that stain looks like, because I've got a nice slide here to demonstrate that. So here's a nice example of the STAT6 stain performed on a needle biopsy, which is certainly the proper use of that. And notice that it's a nuclear expressed marker, and it's virtually every cell. So strong, uniform, extensive expression of this marker should enable you to make the diagnosis. And if we look at the corresponding H&E from this needle biopsy, you'll see that we have some features here that could be very suggestive. We've got the angiectatic or hemangiopericytoma-like vessels. We've got areas of less cellularity. We've got some ropey collagen. So you might have been right at the diagnosis with this just based on the morphology, the H&E appearance of these needle biopsies, and then having the immunohistochemistry, you are able to nail the lesion down. Now, there are malignant examples of this lesion as well. And I don't know that I have one. Oh, here's one where we've got a metastatic. So this earlier tumor that we looked at here was in fact a metastatic lesion. Whoops. So this one that we looked at was a metastatic lesion in a patient who had had this tumor elsewhere. And predicting malignancy in this tumor is a challenge. In this case, the cellularity, the degree of atypia that's present might have helped you, but this is obviously the metastasis. So this is the proof that it's a malignant one rather than the doing so from the de novo initial presentation. So any questions about these two lesions that we've covered thus far? You can feel free to either unmute yourself and ask the question or to put your question in the chat and we will answer that as we go along. So, oops, I'm going to go back here to my presentation list here and take a look at some examples of dedifferentiated liposarcoma. Let's look at it here. Oops. So dedifferentiated liposarcoma, as you are all aware, is a malignant neoplasm that is highly related to the presence, usually a precursor lesion, of well-differentiated liposarcoma. Well-differentiated liposarcoma is defined by atypical pleomorphic cells within the fibrous septi of a otherwise mature-appearing fatty tumor. And then these are known to, over time, have the potential to devolve into a more solid and more aggressive tumor. Now, the interesting thing about dedifferentiated liposarcoma is that the dedifferentiation phase, the development of this solid pattern, can take the form of a low-grade or a very high-grade pleomorphic tumor. And so this is an example of really quite low-grade dedifferentiation in a well-differentiated liposarcoma. And as you can see here, we've got sort of arcing vessels and really quite a bland and low cellularity proliferation of spindle cells associated with this lesion. There are even cases where this tumor can have sort of, if you will, heterologous elements, the development of smooth muscle areas, so that it can almost look hamartomatous in the sense that there can be mature elements of relatively normal differentiated tissue that can arise in this. And that's where the importance of understanding the molecular genetics of this tumor and how it differs from other tumors can come into play. So a low-grade spindle cell proliferation like this occurring in a deep location, particularly in the retroperitoneum, dedifferentiated liposarcoma should be on your differential very close to the top of the list. So this is, even if there's no fat, this is not a tumor where you have to find lipoblasts or anything like that. And in fact, really the defining character in this tumor is the presence of the MDM2 mutation events. Now, we've seen a few cases where rather than having the classic fusion gene with MDM2, we may actually just get extra copy numbers. And that's not defined as a feature of well-differentiated or dedifferentiated liposarcoma, but I believe based on the expression patterns and the morphology that where you define that situation, you'd still probably be led to the diagnosis of dedifferentiated liposarcoma. So here's an example of the expression pattern that can be seen with immunohistochemistry for MDM2. And this is obviously, I think if you were astute there, you picked up that this is probably in a subcutaneous location. So well-differentiated or atypical lipomatous tumor can occur in the deep soft tissues, or excuse me, yeah, in the subcutaneous and deep soft tissues of the extremities, in addition to the intra-abdominal location. But dedifferentiation in those sites is extraordinarily uncommon, and that's why the bias is for those lesions to just refer to it as atypical lipomatous tumor rather than give it the more scary name of well-differentiated liposarcoma. So let's look at a higher grade example of this lesion. And this is actually a case where you may raise consideration for other possibilities. So here's obviously a very, fat infiltrative tumor, a high degree of pleomorphism and atypia in the cells, varying degrees of high cellularity with pleomorphic cells, some inflammatory cells in the background. And if we were to look off to the side here and take a look down here, most likely we're going to find some degree of pleomorphic cells in these septi, and therefore we could postulate that this is the well-differentiated component of this liposarcoma that's characterized by just these occasional pleomorphic and atypical cells within the fibrous septi. And then with this more cellular area representing the dedifferentiated component. Now, of interest here in this particular case is what's going on up here. And as you can see, this is not fatty differentiation, this is osteoid formation. So is this an extraosseous osteosarcoma, or is this a dedifferentiated liposarcoma? Well, as you may know, there are some low-grade osteosarcomas, especially the intraosseous versions, that can also have MDM2 differentiation. And so as a unifying factor, the presence of heterologous osteoid differentiation within a dedifferentiated liposarcoma is probably not too far of a molecular stretch to imagine that happening. Although obviously in this case, the tumor grade of the osteoid component here is not a well-differentiated tumor as we would see in the low-grade intraosseous tumors that have MDM2 differentiation, but is a very high-grade tumor. So dedifferentiated liposarcoma is a very fascinating tumor, both in terms of the molecular progression from a very low-grade, well-differentiated tumor to very highly pleomorphic tumors, or to relatively low-grade spindle cell proliferations, and then the potential to develop heterologous differentiation certainly adds spice to the process and the thinking about this tumor. Jennifer, great question. If we see adipocytes at the interface of undifferentiated liposarcoma, how can we differentiate a well-differentiated liposarcoma versus benign fat cells trapped? So that is a good question. I think in general, an area like this where you've got fat cells admixed with the tumor cells here, these fat cells are trapped. You know, I think it's true that they are trapped, and that the tumor cells that are present in well-differentiated liposarcoma are themselves not necessarily lipogenic cells, if I can be so bold. So even here in the more well-differentiated areas that we have in this tumor, down here, for example, the tumor cells are not the lipocytes. They're these occasional atypical cells that are scattered in between in the fibrous septae and so forth. And so the tumor itself is entrapping the fat per se. It's not so much a proliferation of adipocytes as it is of these abnormal mesenchymal cells that are present in the associated fibrous septae. So I think that thinking about it that way may help you to think about it not so much as a pure lipogenic tumor as much as a mesenchymal high-grade neoplasm that occurs in specific fatty locations and arises from some of the mesenchymal cells associated with that fatty tissue. Now that may be heretical. I'm not a mainstream soft tissue pathologist necessarily, but I think in terms of thinking about how this tumor develops, how it grows and spreads, this pattern of infiltrative growth around the pre-existing fat is much more characteristic of the growth patterns of non-lipogenic tumors like dermatofibrosarcoma protuberans, like pleomorphic hyalinizing angiectatic tumor, these other things we've just looked at that have sometimes also this engulfing and permeative pattern around pre-existing fat until it obliterates the fat. And that's not so much the fat itself that's growing as opposed to the mesenchymal neoplasm that's growing amid the fat. So thank you for that very good question. That's very, I think, very helpful to think about it in that way as well. I think that's all I have on this. Oh, no, that's not a liposarcoma. So it's very common for this tumor to occur in Gerota's fascia around the areas of the kidney and the retroperitoneum and so forth. And as you know, excision or removal of these tumors is extraordinarily difficult just because boundaries are essentially impossible to define. And so surgical control of these well-differentiated liposarcomas is primarily directed towards removal of the dedifferentiated regions, the high-grade areas, with the recognition that you're inevitably going to leave behind some low-grade or well-differentiated liposarcoma. So let's take a look at a couple of other lesions that may have a considerable spectrum of disease. I've got a sequence of undifferentiated pleomorphic sarcomas here as well that we can look at in some detail. And we'll start here at the bottom and work back. So as you know, undifferentiated pleomorphic sarcoma is an evolving category of tumors that is best defined after you've excluded everything else. So what do you need to exclude? Well, you need to exclude things like solitary fibrous tumor. You need to exclude things like pleomorphic hyalinizing angiectatic tumor. You need to exclude various more specific diseases like spindle cell melanoma or anaplastic large cell lymphoma or rhabdomyosarcoma with pleomorphism or pleomorphic leiomyosarcomas and so forth. So these more specific entities are best excluded using a panel of immunohistochemistries that include melanocytic markers, epithelial markers, keratins, myogenic markers, and things like STAT6 and so forth, more specific lineage-derived markers. So in approaching these tumors from that standpoint, it's very useful to look at this tumor as a kind of a diagnosis of exclusion. Now, that said, you may be aware that one of the earlier names for this tumor was malignant fibrous histiocytoma. So why was it called that? The origin of that name derives from cells like this that look like a very bizarre histiocyte. They have a slightly foamy cytoplasm, and there's this background fibrous tissue. So, I mean, this was a very descriptive term for a group of tumors that had aggressive behavior. And at the time and era when that term was coined, we didn't have very many tools to define lineage and to characterize the molecular events that were going on in these tumors. And so that term was deployed. But in our day and age, with more sophisticated tools and an increasing number of tools, we can abandon that term, which really should not be used. Instead, we have this grouping of undifferentiated pleomorphic sarcoma, which describes the tumor as best we can at the present. It's not a tumor that shows any lineage-specific differentiation, so it's undifferentiated. It's very pleomorphic. It has these bizarre high-grade, high pleomorphic cells, and that's usually indicative of a very complex cytogenetic, molecular genetic backdrop or milieu, where these cells tend to have a very complex karyotype and not have any specific predominant mutational changes that would allow us to subcategorize or group them into the category of more specific tumor like myxofibrosarcoma or like solitary fibrous tumor with the STAT6 fusion mutation. Now, having said that, there's sort of a general rule of thumb in soft tissue pathology that the more monotonous the tumor, the more likely it is that that's a simple fusion gene, single mutation related tumor. And so the more pleomorphic a tumor is, the less likely it is to have a specific molecular fusion gene or single fusion gene responsible for that tumor. So we'll take a look at a couple of other examples here of this tumor to illustrate some of the other features that can be encountered in this lesion. Now, necrosis is clearly a defining grading criterion with this tumor, although quite frankly, usually undifferentiated pleomorphic sarcoma should be a grade 3 or high grade sarcoma. So if you are coming up with a lower score, then maybe you should be reconsidering the diagnosis. So here we see this, pleomorphism, the abundant sort of amphiphilic, eosinophilic to slightly foamy cytoplasm. You'll see lots of mitoses, and certainly very likely you'll see many atypical mitoses. Here's an atypical mitosis there, another mitosis here, another atypical one over here. So mitoses are frequent in this lesion, and necrosis or areas of tumor dropout with repair and so forth can be seen with some degree of frequency. Varying degrees of nodularity are seen. And though this tumor probably has some degree of vascular proliferation, the vasculature is not very prominent. So you don't see a lot of characteristic small vessels like we would see in solitary fibrous tumor or certain liposarcomas and so forth. Let's take a look at another example. In terms of immunohistochemical profile that I find to be of particular use in these lesions, I will usually do some combination of pancytokeratin and possibly a low molecular weight keratin like CAM 5.2, as well as potentially epithelial membrane antigen. In terms of melanocytic markers, I usually also will do S100 and HMB45. The picomas can occasionally be high-grade appearing, somewhat pleomorphic tumors. And so including those melanocytic, as well as some myogenic markers like desmin or H-caldesmin is also very fruitful. Here's a lesion. This one has more hyaline fibrous tissue to it, and even some sort of very almost amyloid-like areas here. You might even wonder about the possibility of osteoid formation here in an area like this. We don't have really good immunohistochemical stains for osteoid, and so I tend to rely on polarized light microscopy to demonstrate the presence or absence of osteoid. And that's one of the things that we can't do very well with digital slides. So it's a sad thing, but we're not able to, at this present time, do good polarized light microscopy. Now, having said that, the digital pathology vendors and so forth are moving, with reasonable speed to allow the manipulation of their images in various ways to compensate for that difficulty. So either use the polarization microscopy or other methods that can be adapted to digital slides to derive similar information have been employed. Now, this is a lesion that is actually here occurring inside a structure that includes some muscle. So I don't remember the exact story of this, but this certainly illustrates the fact that there are occasionally intravascular versions of this tumor or intracavitary tumors. But I think this was actually one that was an intravascularly derived tumor. So we'll look at another example. Here, this illustrates one of the difficulties with this tumor, and that is defining margin status. So obviously we've inked the margins on this tumor, but because of the indistinct cutoffs between where this tumor starts and stops, it can be very difficult to define margins. So for example, it looks as though we have a little bit of a fascial plane right here, and that this tumor is spanning the fascial or encompassing the fascial plane. And here we clearly have tumor over here. This highly cellular, highly pleomorphic tumor is our undifferentiated pleomorphic sarcoma. But what do we do with this more cellular tissue here? Does this represent tumor? And this is one of the challenges with undifferentiated pleomorphic sarcoma, is defining where the tumor ends. We don't have a high degree of pleomorphism here. We don't have any immunohistochemical marker that would clearly delineate tumor from non-tumor tissue. And so this is the reason why for these resections, wide margins are required. But seeing this sort of cellular tissue here, abutting the fascial plane, it's slightly bluer and more amphiphilic, I would consider this a positive margin. Now, clearly, that's probably not the critical issue because we've got other margins down here that are more grossly positive in this particular tumor. But margin evaluation in these sarcoma resections is certainly a conundrum at times, especially with tumors like this. We've mentioned the margin challenge with well-differentiated liposarcoma, but this is another example. Now, this is a tumor that also has a very high density of the fibrous component, the collagenous tissue. And some of this may be the pre-existing fascial fibrous tissue that's just been accentuated or added onto, but you can see the variable histology here. And then we'll take a look very briefly at one additional case before we wrap up here. So this is a lesion, obviously metastatic in the lung, and shows you the pattern of infiltration in the lung. So, you know, it's kind of hard to tell here exactly, but I think here's your pre-existing capillaries, and this tumor is growing around the capillaries, extending along the alveolar septi in ways where it has that permeative growth pattern. Obviously, pleomorphism, high nuclear grade, mitotic activity, fibrous differentiation, and this sort of grayish, slightly foamy cytoplasm, maybe with other heterologous things, giant cells and so forth, helps to confirm that this is a tumor that would be in that category of undifferentiated pleomorphic sarcoma. Now, if you're presented with this as just a isolated lung mass, how could you know that this was a tumor? Excuse me. How could you know that this is a soft tissue sarcoma metastatic? Well, obviously, your clinical history is going to be your most important thing to consider. But you know, there are other things that could occur like this that you would want to exclude. So you'd want to exclude a sarcomatoid carcinoma. That's where your keratin markers would come in. You'd want to exclude some of the primary pulmonary sarcomas that you might encounter. You'd want to exclude solitary fibrous tumor as a possibility as well. So those lesions, those entities would be in your consideration and differential evaluation. Well, we've hit 8 o'clock. I know many of you have things to get on to in your general workday. So I'm going to stop at this point and we'll entertain any further questions that you want to bring up. Again, reminding you that Dr. Adeyu will be here next Friday with a special session of Sign Out with the professor. So please come back and join us next week for his cases. I appreciate you tolerating my sort of off-the-cuff discussion of some soft tissue lesions, and welcome your comments or questions either now or if they arise later. Please don't hesitate to reach out to me and send me your thoughts or questions about any of these entities or other cases that you may have. It's always a pleasure to have you with me, and so not seeing any additional questions, I'll just sign off for today and wish you a good rest of your day.